Very good evening for today, my beloved colleagues. Hope all of you are in good health by the mercy of Almighty. Today is very latest and interesting topics we have planned to discuss with you. And already you have seen the topic is diabetes mellitus, mainly the management part according to the NICE guideline published very recently of 2026. As NICE guidelines, a reference guideline for AKT and OSCE, so everybody should know it. For this reason, we invited the AKT and OSCE both candidates. Moreover, it will be useful for any practitioners as well in our day-to-day life practice, because NICE is the most famous guidelines in the world. So with this introduction, and in addition, I like to add, review means those who are using the module, you have gone through many topics, possibly diabetes mellitus as well. Today, when we will be discussing the clinical problems with you, definitely it will be enough to give you a glimpse of the review of the topics in very short time. And we will not talk too much today, as before you have attended with our trap question type discussion sessions. So hopefully within very short time, you can come around the diabetes, especially focusing the management part. There might be some confusing thing for you, and this is the time to correct ourselves. So let's go now. It's my humble introduction, and from the institute as well, congratulating you, welcoming you with the moral alert. The topic is already mentioned before. So the first patient now. So please, who want to read it, please? Anyone? Don't send the all balls to me that I will read. Please, anyone? I think Dr. Javed. Can I
Assalamu alaikum.
welcome you? Salam. Please, Dr. Javed.
Okay,
This is our first patient today.
okay. Yes. A 56-year-old man is newly diagnosed with type 2 diabetes mellitus during a routine health check. His HbA1c is 63 millimole uh, per mole. BMI is 31 kg per meter square. eGFR is 82. According to NICE 2026 guidelines, which is the most appropriate initial pharmacological management.
Thank you very much, Dr. Javed. As it is mentioned, NICE 2026. So if you give the answer of the previous guideline, your answer will not be correct. And I appreciate you that you will do the same. Even NICE 2026 not mentioned also in forthcoming exam. Keep in the mind. Now choose your answer, please. Anyone?
I think C.
C, modified release metformin plus SGL2 inhibitor. Okay. Dr. Sharmin,
Sir, modified release metformin alone.
alone.
Yes,
Right.
sir.
Very right. And this was also a concept. Any colleague to add anything additional? No. So can switch now. Let's see. So Dr. Javed answer is very right. And Dr. Sharmin was right 1 year before, not today. Okay, Dr. Sharmin?
Sir.
And still, many colleagues are practicing these things. Still now, those who are not well oriented, they are starting only with the metformin. Okay. Very rare cases, you can start with the metformin if you think that patient have repeated urinary tract infection, many other issues. You are actually feeling restricted to add sodium glucose transporter 2 inhibitor at that time. But otherwise, in general, the advice is combination of the modified release. Remember, modified release also important, not plain metformin. This is the correct answer, because it is found that these sodium glucose transporter have some important role for cardiovascular protection, renal protection, even in the heart failure also it has some role. What does it mean? It means even patient does not have diabetes also, ex expert can utilize it in the setup of heart failure. Clear, Dr. Javed?
Yes.
Not only for glucose lowering medication, rather if patient have the heart failure due to any other reason, with expertise opinion, we can use this, even the like dapagliflozin, empagliflozin, so on. And other actually you understood the why others are not correct here. Let me read. Insulin usually not the first line, but insulin first line if there is severe symptomatic diabetic patient, hyperglycemic patient. And the second one is the old guideline, modified release metformin alone, what Dr. Sharmin said. And the D-sulfonylurea has chance to create the hypoglycemia initially, but in some situation, sulfonylurea can be used at the first time if patient have the symptomatic diabetes. Patient doesn't allow to give insulin. In that critical situations, alternative ways, sulfonylurea, when we expect to reduce the blood sugar a little earlier. But it will not be your answer here because first time you are treating the patient according to the guideline. Patient does not have severe symptom. Rather, what is said, patient in having a routine health checkup. Newly diagnosed patient and captured the diagnosis in the routine health checkup. So routine means almost no symptom. Anything, doctor, you like to discuss here, please? A new thing you understood and learned today? No more? Dr. Aisha?
So, sir, in OSCE,
OSCE, yes,
we
you
will
must
be
say, Dr. OSCE, according to the guideline. It's a very simple guideline and latest guideline. In coming OSCE, you must answer it, doctor. Remember it. Remember it.
and what will be the second line, third line?
No need to ask second line, doctor, in the OSCE. OSCE will tell only the
Okay,
first line medicine management all the time. No need to learn second line.
okay,
Okay. Second line not mentioned also, doctor, clearly. Second line means alternative according to your patient's situation, you will choose. Okay.
okay.
Thanking you. Dr. Aisha, can you read it for us? Second patient.
Yes. A 68-year-old woman with type 2 diabetes mellitus has a history of heart failure with a reduced ejection fraction. HbA1c remains elevated despite metformin. Which additional drug is most appropriate according to NICE 2020?
Yes, diabetic patient as well as reduced ejection fraction
Hmm.
heart failure.
AMPA. AMPA
EMPA is
study.
very clear now. I think this is the answer. Everybody
Hmm.
understood that we discussed also. So what will be the trap here? Trap that you see previous pioglitazone rather causes fluid retention. Glycoside does not have role. Sitagliptin does not have role. Insulin does not have role. Only empagliflozin have positive role in the heart failure. So sorry, the
This
pioglitazone.
is even according to the old guideline. Even in the old guidelines, whenever the patient is with some heart problem, we start AMPA.
EMPA.
No?
Yes, yes, it is mentioned before if patient have the diabetes. Okay,
Hmm.
empagliflozin patient have the diabetes. So the 2026 doesn't mean that everything is changed. Absorbing the previous thing, they refresh with the new thing. Okay, finish. Dr. Aisha, can you continue this one also? Third patient,
Yes, of course.
please.
It's a 72-year-old frail man with the type 2 diabetes, lives alone. HbA1c is 60 millimole per mole despite metformin. He has recurrent falls and mild cognitive impairment. Which add-on therapy is most appropriate?
Very right. What
Right.
are the
Mhm.
comorbidities, Dr. Aisha? Your patient is
Mhm.
diabetes mellitus. In addition, what are the
Mhm.
comorbidities other than diabetes?
One is mild cognitive impairment,
Right.
And the other one is recurrent falls, maybe
Fall.
osteoporotic, maybe postural hypertension.
Could be, could be. If we want to add, we can say that patient is frail, not apparently
Hmm.
healthy, right? Vulnerable patient. And age also 72 advanced age. So why I am
Mhm.
asking in this way? In designing a treatment, any disease treatment, we have to consider all the comorbidities. It's a very basic principle to decide. So patient is on therapy now, HbA1c not good. So what add-on therapy will you give? Patient is on metformin before.
Mhm.
Please,
I think
anyone
in
can
this
try.
condition, theta,
Which one? Sitagliptin.
theta.
Sir, dapagliflozin.
Dr. Sharmin telling dapagliflozin, sodium glucose 2 inhibitor. Why not sitagliptin, Dr. Sharmin? Just asking you, crossing you to test your understanding. Don't say by
According to the
lottery, Dr.
guideline,
Sharmin. Don't say by lottery. You have to have some idea that why this is not. Dr. Aisha, to add anything?
I was saying according to guidelines, it should be DAPA, but
According to
it
guideline, it
is
should be
causes.
DAPA. Okay. Why?
Mm,
Why? What is the background data to
mm,
use DAPA? Dapagliflozin. What is the background? Is there any heart failure? Is there any other issues? Renal problem, cardiac problem? No problem.
in this scenario, there is
I
nothing.
say I
But
agree.
again,
But but
DAPA
but yes, DAPA in a sense that if you think step up treatment, your old patient getting metformin, definitely we will add DAPA, no doubt.
mm,
But considering the comorbidity, can DAPA be a little bit problematic? If it is true,
like it can
you
cause.
will not
Mm,
use dapagliflozin. Understand, Dr. Javed?
Yes. But I think in this case should be DAPA because in frail patients we can use because it doesn't cause hypotension. Dapagliflozin.
So
but it can
dapagliflozin
cause
causes
some urinary tract
hypotension.
infection.
It can cause urinary tract infection. So are you telling in
Mm,
favor of DAPA or against DAPA?
Dapa not suitable.
against.
Yeah.
Yeah, Dr. Abu
It's
Omar.
fall.
Abu Omar, right?
Yes, because falling.
Yes, because falling. So DAPA will not be good choice, isn't it?
Mm,
If it is
I
not
think
true, correct another
I
one.
will go for DAPA number after this sitagliptin.
Oh, you are
PPP.
choosing DAPA. You need to choose only one, Dr. Javed, not more than
Okay,
one.
DAPA.
DAPA,
First
okay.
choice.
But why you are not agreed
Sita.
with Dr. Abu Amar that DAPA can cause hypotension?
DAPA doesn't cause hypotension.
Doesn't
Dapa, it
cause?
is SGLT2 or not?
Yes. Sodium glucose
Because the
transporter
urination will
inhibitor.
kiss.
It
UTI, yes.
increase not ETI only, it increases
Increase
the
the urine
urine
frequency.
output. It causes hypotension, Dr. Jabir. Okay. So other than DAPA,
Sitagliptin.
sitagliptin, pioglitazone, glibenclamide. Why not glibenclamide?
That will cause hypoglycemia because already
Hypoglycemia also.
Hypoglycemia, already frail patient. Patient have cognitive impairment also, right? So why not rapid acting insulin?
detecting. If
Again,
blood sugar control,
hypoglycemia.
I think next step that can. But right
Again,
now,
chance of hypoglycemia there, but indication of the insulin here, is it severe hyperglycemia with the symptom? No. No. So remaining sitagliptin, pioglitazone. Sitagliptin, pioglitazone. What is the complication of pioglitazone? One is the
fluid
fluid
retention,
Fluid
retention. Fluid
retention.
retention.
contraindication, heart failure is there, then it's contraindication.
So remaining thing sitagliptin. Okay. Hypoglycemia less found in the with the sitagliptin. Weight neutral and dosing simple. So you already discussed it. And pioglitazone causes edema as well as fracture. Fracture means osteoporosis. If it is true, if frail man fallen down, there is more risk of the fracture. Clear? Now, Is the question very easy? What do you think? It's a very simple like question. Dr. Abu Amar,
Yes.
are you from, please? Which country?
Assalamu alaikum. Now I
Dr.
am hearing from Saudi Arabia.
Saudi Arabia, right. And your Arabic, I understood, Alhamdulillah, a little. Abu Umar, if I am not wrong. So, can you say, is it a very difficult question? Simple question? Possibly
It is
no.
a simple question, but need from you to be concentrated about
Yes, yes.
calling and don't go like the first line is daba and check it. No,
Very right.
you
Very
must
right.
think
We
before
have to
answer.
know, about each and every drugs used in the diabetes treatment. Not only randomly choosing one
That
drug,
is a
giving the
good question, by the way.
right,
Good
right,
thinking.
right. Brainstorming. Next one. Dr. Abu Omar, can you read it? Can you read it for us? Actually, we are discussing the patient, doctor.
Yes,
Please.
61 years old woman with type 2 diabetes mellitus and body mass index 38
8
kilogram. Uh, remain above hemoglobin
above the target.
A1C
Above
above
target.
target. Hemoglobin A1C
Despite
above target despite metformin and imba,
giflozin.
empagliflozin.
Okay.
She wished to lose weight. Which
What is
is
the
the most
appropriate?
appropriate therapy?
Thank you. Please answer. Chaturanga. Chaturanga.
Semaglutide.
We open the Dr.
Yeah,
Aisha.
semaglutide. Semaglutide, sir.
Semaglutide. Semaglutide. Okay. Okay.
Semaglutide.
Semaglutide. Because we are practicing this semaglutide. So there could be another drug other than semaglutide. For example, semaglutide is not there. What could be other alternative?
Liraglutide.
Liraglutide.
Liraglutide or tirzepatide.
Acarbose. There is a
Tirzepatide.
acarbose.
Tirzepatide. Fine. Gliclazide weight gain, insulin weight gain, pioglitazone. If edema is there, there is a chance of weight gain also. Acarbose, GI side effects, right? Much. It is not the first line medicine as well. And not used for the weight loss. Sometimes we use metformin, but it is not recommended for the weight loss as weight losing medicine. Okay, GLP-1 receptor antagonist. My beloved colleague, don't be confused with the DPP-4 inhibitor. Okay, this is also in creatinomimetic drug. Okay, in creatinomimetic drug, but there are two types. One is the receptor inhibitor, another is the direct receptor agonist. Another one, enzyme inhibitor, receptor agonist. So there should be a distinction. Okay, next, who want to read again? Please, Dr. Shaturanga, please, if you don't mind,
Yes, sir.
please.
It's still going. 58 years old man with type 2 diabetes has EGFR 24 milliliter
Four.
per minute, albuminuria, persistent hyperglycemia. He is already taking metformin, which is now stopped. According to NICE 2026, which class is most appropriate to continue cardio-renal protection if tolerated?
Okay.
B.
B.
Yeah, SGLT2
B. I
inhibitor.
think B.
Yes.
Everybody will
And
agree with the B.
yeah.
Pioglitazone.
No,
Or
no,
the
second one.
third, second
No,
one.
sir. B.
B. Right,
CLT.
right. Already you learned today, right? Within these few minutes. I think the market of SGL2 will be high up, lifted up within this year. What do you think?
Yes, sir.
Still, I think our pharmaceuticals, they are preparing to advocate this medicine in our chamber. Okay, but unfortunately, our doctor colleague don't know, those who are not oriented with the latest update. And you will be in trouble, especially in the coming OSCE, remember, because diabetes is a very common topic. There should not be any confusion. Right. Okay, so what is the trap here? Candidates often stop SGL2 inhibitor too early because they focus only on glucose lowering rather than renal protection. What do you understand by this? It means that if you think that the blood sugar under control now, better to stop this SGL2 inhibitor and continue metformin or other drug. Better not to stop it. Metformin plus minus. If blood sugar become very low by the lifestyle, any other, if you are worried that patient might have hypoglycemia, at that time only you can consider to stop. It is true, first line is metformin. If metformin cannot be given, patient cannot tolerate, then the second line, I think Dr. Sharmin or someone asked about the second line. Second line always will be sodium glucose transporter 2 inhibitor. Okay. Third one, Dr. Chaturanga, please, if you don't mind, please
Yes.
continue this.
Yeah, sure. Still loading. Yeah, 49-year-old man with newly diagnosed type 2 diabetes mellitus asked why his doctor prescribed modified release metformin instead of standard metformin tablets. What is the best explanation according to NICE 2026 updates? It causes
Oh,
more
no need to
weight
read
loss.
option, doctor. Thank you. And look at and choose the answer.
C.
Yeah. It is
Some colleague
not
telling C.
available.
C means it has
C.
fewer GI side effect, adverse effect. What do you mean by this? That modified release metformin causes less side effect, is it?
Yes.
Yes, sir. Yes, sir.
Oh, I see. Others are not correct. One by one, please explain, Dr. Sharmin. It causes more weight loss. True or false?
False, sir.
False.
False.
It reduces
False.
risk of
Same.
ketoacidosis. False. It reduces.
False.
It reduces.
No.
That means a
No,
modified
sir.
release. No. It lowers HbA1c more rapidly.
No, sir.
No. So what is
No.
yes? Less rapidly. It lowers
Yeah.
A1C,
Yes.
no doubt, but less rapidly. It
Yeah.
eliminates lactic acidosis risk. Is it?
No,
That
sir.
there is no chance of or less chance of lactic acidosis if we give modified release? It is also not correct. Chance of lactic acidosis could be there, but for the GI issue, modified release is the advocated drug now as a first line. Okay, thank you very much. Thank you very much. Eliminated. Dr. Sharmin, please go through this patient.
A 64-year-old woman with type 2 DM and previous myocardial infarction has HbA1c above target despite metformin. Which option provides the best cardiovascular benefit according to NICE 2026?
Which option? Best cardiovascular benefit. Which one? There is no SGL2 inhibitor, right? One colleague trying to tell, written Samsung, sorry, your name is not mentioned. Do you like to answer it, doctor? Samsung SM written here. Please choose the answer. Dr. Javed,
C.
C.
No, sir, I'm
Semaglutide.
Masterclass.
Semaglutide, pioglitazone, carbose, semaglutide,
Yes.
body weight reduction, we already know. In addition, you are telling that
About
it will give some cardiovascular benefit, right? Patient with a stop
previous.
list. So we must remember these things. Patient with cardiovascular problem, atherosclerotic cardiovascular disease, two drugs, SGL2 inhibitor and GLP-1 agonist drug. Remember it. So patient should have it. Should have it. It reduces major adverse cardiovascular events and promote weight loss as well. Okay. So sulfonylurea improves glucose status, but does not give cardiovascular benefit. And I believe that still in many, many countries, people are taking the glibenclamide also. In the Middle East, I think Dr. Abu Omar, can you talk to me? I don't know, still one drug, metformin with glibenclamide. Is it? What is the name?
Yes, sir. Widely
Glucovans.
used, sir. Glucovans. Yes, sir.
Glucovans in
Yes,
the
sir.
Middle East country. When
Yes,
I
sir.
was there, I could remember since this time. It's still there. Glucovans is a very high profile company produce it. So we have to be away from this. Okay. Dr. Sharmin, I think you will not write from tomorrow.
Yes, sir.
Glucovans.
Sir, there is a problem that na the insurance companies they are not like giving approval to SGLT2 or GLP-1 receptor sometimes.
It is sometimes, doctor, it happened before. Already guideline established. If you give treatment according to the guideline, nobody will ask you. If you have, suppose you are in UAE or someone in Saudi Arabia, if you have national guideline differently, then different thing. But still country doesn't have national guideline, you have to follow standard guideline. And if
Yes,
you
sir.
utilize it, you will argue with the insurance company. Don't worry. Okay. And I had this
Yes,
experience.
sir. Yes, sir.
I had talked to them with the insurance company very often. I was strong enough at that time. No problem. So you are learning today, you will utilize it. Don't worry. Dr. Javed, come back please with the patient.
Sure, sir.
Always you start with us. Yes, please.
A 55-year-old woman with type 2 diabetes mellitus has recurrent severe hypoglycemia on glycoside. HbA1c is now 49 millimole per mole. Which medication class is most associated with hypoglycemia? I
Oh,
think it's clear. Sulfonylurea.
sulfonylurea. How simple
Yeah,
question could it be, right?
yes,
But you will be confused that, oh, I think DPP4 can cause hypoglycemia, other. It will create some confusion. So we need to be very confident. I will show you in the later part today a comparative chart also. I hope it will be more beneficial for you. Okay. So the common trap is candidates underestimate hypoglycemia risk in elderly, renal impairment, and irregular eaters. Remember it. Whatever the drug you are giving, elderly patient, renal impairment patient, irregular eater will have more chance to develop hypoglycemia. Okay. Can I tell one story 1 minute? I think some of you might know. Story means patient story. Patient is on insulin treatment for a long time for the uncontrolled diabetes. After a few days, advanced patient, 50-year, 55-year diabetes for 10 to 15 years. After increasing the insulin, few weeks later, patient came to you with the hypoglycemia. Practically, you couldn't expect it that very rapidly patient develop hypoglycemia. What could be the reason behind? This is called clinical experience, not only reading the book. Yes, please, any colleague?
Sir,
Sort
maybe
of
patient took insulin and he didn't eat anything.
renal
Could be,
impairment,
could be,
which
could
causes
be,
reduced metabolism of
could be.
insulin.
But I'm just why I'm telling this story. You patient you know about, he was not irregular in the diet before, because when you are increasing the insulin, definitely you have educated the patient. Don't miss your meal, other thing. You are giving the training, so there will not be any problem. Okay. And patient age is 50, 55, not too much elderly also. Reason behind is patient might develop diabetic nephropathy. Okay. This is the solid answer. That means we must think of it. If insulin in very short time after increasing the insulin dose, even not increasing the dose, patient is on a standard insulin, it was controlled rather 1 year. Clear? Dr. Sharmin and everyone. Patient in
Yes,
a
sir.
follow-up 1 year, patient is on insulin in standard doses. But in the one follow-up, you found that without any changing insulin, patient got hypoglycemia. You cannot explain otherwise. Remember,
Mm.
patient might develop renal impairment and insulin half-life become more. Okay?
Okay.
Just clinical tips I shared to you. You will be aware of this. Number 9. Yes. Doctor, please, who's my, I'm sorry, I cannot utter your name. Samsung Rayton. Can you read it for us?
A 60 years old man with
Type 2 diabetes mellitus.
Type 2 diabetes has HbA1c 92 millimole per mole.
That is 10.6%.
10.6%. Polyuria, weight loss.
Ketonuria negative.
Polyuria, weight loss.
Ketonuria negative means there is no ketonuria. Okay. So which is the most appropriate management now?
Which is the most important?
Okay, please choose now. Choose your answer.
Basal insulin.
Sir, basal insulin initiation.
Basal insulin initiation. What is your philosophy, Dr. Sharma,
60
that
years
you
old.
like to start insulin?
Sir, because HbA1c 92, by oral agent it will not come down first.
Is it the only reason?
Answer,
Patient having symptomatic diabetes, rather to say.
yes, sir. Yes, sir.
Polyuria, weight loss, these are
Hmm.
standard traditional symptom of the diabetes.
Yes, sir.
Recognized symptom of
Yes,
diabetes.
basal insulin is
Considering
better.
everything, not only the HbA1c, though there is an indication more than A1c such value, you can consider, could be, okay. But ketonuria negative, is it against your against your decision?
No, sir.
How can you explain ketonuria negative? Ketonuria is the features of the diabetic ketoacidosis. Okay.
Yes, sir.
So
Yes, sir.
indication of the insulin is not only diabetic ketoacidosis. Indication of insulin even other than diabetic ketoacidosis. That is a
Yes,
symptomatic
sir.
diabetes. So your answer will be possibly right. Basal insulin initiation. Okay. But you might switch to basal bolus also few days later. Okay.
Okay, sir.
Basal bolus also. And the message will be that do not delay insulin in symptomatic patient. Usually for practical purpose, sometime we cannot convince the patient. We could do. We are delaying. Okay, come back. This is the practical patient to patient variations. But in our decision, especially in the exam hall, be confident about this, that insulin will be the medication now to start with. Dr. Abdul Latif Al-Sad, may I request to read the 10th patient?
Yes, doctor.
Welcome, doctor.
63-year-old, welcome to you, doctor. 63-year-old obese man with type 2 DM is on metformin, pagliflozin,
Empagliflozin and
semaglutide.
semaglutide.
Her hemoglobin A1c remains above target. Yeah, target. Which is the most reasonable next escalation?
What will you do next? Okay. What will you increase? Thank you, doctor. So everybody now share with your answer. Patient is on 3 drugs now: metformin, empagliflozin, and semaglutide. Obesity is there. For that you have given semaglutide. Still HbA1c above target.
Sir, add sulfonylurea or basal insulin depending on individual risk.
You will add sulfonylurea or insulin. Okay. Other colleague having different opinion?
Yes, sir, because the option left is A.
Only A. Oh, stop all. Add another GLP. GLP-1 is remaining drug to be added. You are not adding GLP-1. Why?
Because semaglutide is already there.
Semaglutide. Is there any
Also
prohibition? Is there any
GLP-1.
prohibition that add another GLP-1? Oh, one
No, another
GLP-1
can
there. Oh, we cannot
One.
add another one. We can replace somehow or it is not working. Start
replace, but we cannot
long-term
add
steroid.
another one.
Yes, switch to acarbose alone. Oh, I think A may be the best, right? A may be the best. That means still patient needs blood glucose reduction. So we will add sulfonylurea or basal insulin. Individual risk means patient may not be suitable for the insulin injection. At that time, we can use sulfonylurea. So now you understood sulfonylurea in general at the very bottom, right, Dr. Javed? But 20 years before, 30 years before, we just start with sulfonylurea. And I shared with other Middle Eastern colleague, those who are working there, glucovans. I think those who are not in the Middle East, you don't know this trade name. Glucovans. Somebody say glucovans. This glibenclamide. Okay. So nice
Sir,
principle.
Amaril also.
MRL also is still is a very cheaper doctor, comparatively cheaper medicine. So
Yes, sir.
in very specific situation, patient is very poor, you are restricted by the insurance company, still you need to use sulfonylurea. And glibenclamide is very strong drug to produce hypoglycemia. So better to avoid glibenclamide and use even glimepiride, gliclazide, you can use in another way. But better to avoid glibenclamide. But what is one important quality, good quality of glibenclamide? Who can say? In female? In female, I'm giving some prompt. Glibenclamide is better than other sulfonylurea. Though it produces hypoglycemia, in the female, Dr. Litton here in action.
Yes, sir. Sir, previously, glibenclamide can be used in pregnancy.
In the pregnancy, glibenclamide can be
Yes.
used as oral sulfonylurea in pregnancy, but others sulfonylurea not.
Uh, yes, contraindicated, sir.
Yes, other sulfonylurea. Thank you. So after this patient, already we discussed 10 patients for you. I hope that it will update your knowledge and your practice also according to the latest guideline, and it will be useful for the decision making in your coming OSCE and even in the coming AKT exam. I hope that both are mixed here today. Now, something about drug class comparison. And when you listen or when you see there, you will be very impressed, I believe. Let me say now. In the drug class comparison, we are comparing very common drugs according to the parameters. What parameters? Weight effect, hypoglycemia risk, cardiovascular benefit, renal benefit, and some other problem. Other problem means adverse effect. Considering these things, and these are very practical issues to be considered during the prescription of the diabetic medicine. You see now, please, everyone, let think more by myself, not to talk more also. So you check one by one if you need. Sorry, doctor, someone having the noise. Okay. You look at and you can discuss or ask me any question, please. Don't think that I will read one by one here. Okay, what you know beforehand and you check your knowledge. I request you, especially main problems, better to be known. Whenever we prescribe any medicine, we have to know the adverse effect first, considering is there any dangerous adverse effect or not. And this will be your exam question issue. Dr. Litton, clear everything? Metformin, go to the right.
Yes, sir. Yes, yes,
Two.
yes.
GLP-1 receptor nausea, injectable, especially in injectable, create the nausea. Rather, nausea is useful for management of the obesity. DPP-4 weight neutral is very good one. Okay. So in general is a very low DPP-4 inhibitor, hypoglycemic effect is very less, very low, even less than metformin also. I think it is very striking, Dr. Layton. We thought that even by myself, sorry to say, it was better glucose lowering than metformin. But now it is written is a very low. But why it is given? Because weight neutral, okay, and efficacy modest, weight neutral. So DPP, Dr. Litton, the DPP-4 inhibitor is flooded with us in our country, is not it? And I
Yes,
believe
sir, exactly.
I believe you have prescribed a lot of DPP-4 inhibitor in your life. Is that it?
Yes, yes. Exactly.
Now you realize what we have done, what you have done.
Sir,
Somehow we are.
it's a very common drug, but there are some benefits also.
But benefit,
this is
rather to say renal benefit, renal. Sometime DPP-4
yes.
inhibitor can be used in the renal impairment. It may be some benefit, otherwise not comparatively. If you consider the cost, I think
Yes,
it is not a
yes,
good
yes,
choice. It's a costly medicine.
definitely.
Okay, right. Again,
Sir, very low means here the hypoglycemia risk, na?
hypoglycemia risk is very, oh, sorry. What about hypoglycemia risk means it is indirectly you can think that glucose lowering effect also not too much high also. From this sense I'm telling. Sorry, doctor, you
Okay.
corrected me a little here. Thank you very much.
Yes, sir, I can add
I was
something.
actually
As
focusing the
it's
cost.
a,
Okay.
yeah, it's the incretin mimetics. That means it augments insulin secretion. In this pathway, sitagliptin, vildagliptin, or works in this way.
Yes, very right, very right. So if we say in an refined manner, which drug is best glucose lowering? Just to be clear, don't be confused. Which drug will be the best glucose lowering drug?
Sir, insulin, obviously.
Very right,
Insulin,
insulin.
insulin,
And
insulin.
then
Then sulfonylureas.
sulfonylurea. That's all. Other things are almost border. 1920 we say. Okay, right. Dr. Sharmin, you noticed very nice thing here. I think my voice was not clear my talking was not clear to you. Okay. So in the clinical situation, what will be the drug of choice? Already we discussed in our previous patients. Again, we're refreshing our memory. Number one, let me discuss. In the clinical situation, there are 1, 2, 3, 4, 5 clinical situations. Means these are the commonest clinical situation we face with diabetic patient. Okay. So Dr. Litton, can we explain our first clinical situation? You start with this one. Dr. Litton.
Sir, couldn't understand.
You describe this clinical situation one. What will be the drug and why? You just
Yes.
go through this.
Newly diagnosed type 2 diabetes mellitus in most adults. Preferred choice of the drug in first line, modified release metformin with SGLT2 inhibitor.
If the guideline is
Preferred,
telling. Okay.
yes. Early cardio-renal protection, but there are 2 to 3 drugs then we can add in addition to metformin, like DPP-4 inhibitor, sulfonylurea, and SGLT2 inhibitor.
In the later
And
on, not
these
initially, newly
in the
diagnosed.
later,
Your
yes,
patient is newly diagnosed. So why you are going further?
yes.
Is a newly diagnosed. But avoid and caution, they didn't mention anything in my collection. But we will have some caution. Dr. Litton, what caution could be there for
So
metformin and
urinary tract infection risk. If we prefer SGLT2 inhibitor in addition to metformin, sir, in a newly diagnosed type 2 DM.
no, avoid, doctor, caution. That means you will avoid the medicine or you will be cautious to use this metformin and sitagliptin too. Sorry.
Yes. Yes.
Glucose.
SGLT2 inhibitor sometimes can increases the risk of diabetic ketoacidosis, euglycemic
It
ketoacidosis.
is very rare.
Yeah.
It is very rare and it happens. So then you will stop. But rather,
Yes.
why not telling the UTI chances there? Your patient having recurrent UTI.
Yes.
At that time, we need to be cautious. Okay. I'm just telling
Okay,
some
sir.
additional informations. Patient have the eGFR is very low. We have to be cautious, right?
Yes, sir.
Yes.
Metformin. Patient might develop lactic acidosis. Some other reason is there. We have to be cautious.
Yes, sir.
For example, patient have acute left ventricular failure. Should we continue metformin or even should we start metformin? No. Metformin can be given in the chronic heart failure patient.
Stop metformin, sir. Stop metformin.
If continuous, stop metformin. But again, our focus is newly diagnosed type 2 DM patient. They didn't mention about comorbidity. So no need to be cautious. This is the message here. Okay. I just
Okay.
added something extra clinical scenario for you, nothing else.
Sir, can I ask one thing, please?
Why not? This is the time to ask.
Sir, like one obese patient comes with diabetes, then can I start GLP-1 first, or I have to go through the guideline like first metformin plus SGLT2, then GLP-1, or directly I can start the GLP-1?
You can start the GLP-1 agonist as well. Why not?
Sir,
Your
three
target,
together?
doctor, why not 3 together? This is an additional clinical clue. Patient having comorbidity for the obesity. Clear? Just
Yes,
try
sir.
to
Yes, sir.
understand the word newly diagnosed T2DM, not mention obesity or other. Obesity is another feature here. Okay?
Yes, sir.
Even you can start with semaglutide only if you think that patient needs body weight reduction is mandatory and earlier. Okay?
Okay. Okay, sir.
This is the thing. Even you can use 3 also, but you have to consider the blood sugar level, A1C level, initial level, then 3. Otherwise, patient might develop somehow, patient missing the food and other. Many clinical composition will be there. But for the body weight reduction, you see, Dr. Sharmin, you go through the second patient, second clinical
Yes, sir. Yes, sir.
obesity and patient need
Or
weight
need
loss.
weight loss.
So GLP-1 receptor, it is the preferred. Understand now?
Yes, sir. Thank you, sir.
You may add or may not add also metformin. Better to add metformin minimum. Okay? Better to add
Okay.
metformin. So our practice could be a little bit modified also, no problem. But only the thing, only diabetes, nothing else. So why preferred? A strong weight loss plus cardiovascular benefit and caution. Please read it, Dr. Sharmin. Cautious. Why should we be cautious? Obesity, we will
Sulfonylurea,
not,
yeah.
yes. We can add
Sulfonylurea,
sulfonylurea.
pioglitazone, and excess insulin, it will increase more weight.
Yes, increase body weight. So we will not, usually we will not choose this drug. Thank you. Dr. Javed, please explain the third one.
It's heart failure with reduced ejection fraction and
Or
with
preserved ejection fraction in both situation.
ideal drug will be SGLT2 inhibitor.
Inhibitor.
And because it reduces hospital admission
Yes.
and mortality. And
In the heart
pyoglitazone
failure, it is heart failure, remember, not the coronary artery disease. Only heart
is
failure. Only heart failure. It is better. And pioglitazone, better to avoid. Okay? Better to avoid. And the next one, Dr. Javed, please continue. Established atherosclerotic
cardiovascular disease,
disease.
which includes MI, stroke, and peripheral arterial disease. In this case, SGLT2 inhibitor
and or GLP-1
GLP-1
receptor agonist.
Because both has cardiovascular benefit.
Yes, cardiovascular benefit. So remember again, trap is there. Only heart failure is only one drug chosen. But atherosclerotic disease, both can be chosen. We can combine also. Right? And this very common accompanying complication in ischemic heart disease, patient might develop heart failure. So at that time, we can use both. So if patient having initially both drug, what will we do now, Dr. Javed? Heart failure is an outcome, but patient have myocardial infarction. So you started SGL2 inhibitor plus GLP-1 receptor agonist. Patient develop heart failure now. Will you withdraw the GLP-1 receptor agonist? Please, anybody can answer now. It's a quiz question. Very intelligent
GLP-1,
question. Will
I
you
don't know
will
because
stop it?
GLP-2 is
Because
given
it is
for
written, no, doctor, it is written as GL2 inhibitor in the heart failure situation. I am telling you the scenario, patient previously atherosclerotic disease, now develop heart failure yesterday. Will you stop the
Sir,
GLP-1 receptor?
sir, we will stop GLP-1 and we will switch to SGLT2 inhibitor.
There is no switch. Patient is already on the 2 drugs. So will you stop GLP-1 receptor agonist?
No, sir. No, sir.
Then we will continue, sir.
Yes. Because
Continue
who
both,
has
sir.
the heart failure? This patient already have the atherosclerotic disease, Dr. Javed.
Yes, sir. Yes, sir.
Clear now?
Yes,
It
should
doesn't
be
mean
continued.
that patient does not have atherosclerotic disease now, newly developed heart failure. It is not possible. This is the intelligent question. Clear? Very right. Very right. So who will learn it, doctor, by reading the book only? Those who are not with us today. Without discussion, everything will not be clear. And then Dr. Javed is continuing, maybe proven cardiovascular
Chronic
benefit
kidney,
and
chronic kidney.
sulfonylurea as sole escalation, right? Why prefer as a sulfonylurea is a sole escalation? We will not increase the we will sole escalation means
We will avoid sulfonylurea.
actually we have to
Solely we will
avoid
avoid this
sulfonylurea.
one.
Yeah, better to avoid it. And next, Dr. Javed, CKD with
CKD with
albuminuria.
albuminuria. So here also SGLT2 inhibitor because this provides renal protection.
Renal protection. It's in last few, actually maybe 5 or 10 years observation happen. Okay. So
And metformin,
yes, if severe renal
renal
impairment, we will avoid the metformin. So there is an again a GFR value, cutoff value is there when to stop the metformin.
Can I ask something?
Please, please.
Metformin below 30 will be we will try to stop.
Usually below 30. Even then, the clinical concept is try to continue metformin if patient's renal status is stable. Near about 30 eGFR, patient is on metformin, we can continue also because patient in frequent follow-up, we find patients is stable and there is no other chance of lactic acidosis. We can continue metformin. This is an expertise clinical decision because metformin have many other benefits.
30 to 25, so that in that case we will stop.
Could be, but near about 30, for example, 29. If I continue also, no harm almost. Though there is a cutoff value, it metformin giving some other benefit. There is only a border situation. But for the for this reason, Dr. Javed and everyone see that it is mentioned metformin about avoid or be cautious. Remember, avoid or be cautious if there is severe renal impairment. Okay, not that it is totally prohibited. This is the way of learning, understanding the meaning. And some other clinical situation now. Please, Dr. Javed, please continue a few situation. Frail elderly.
Sorry,
elderly, DPP4, yeah, DPP4 inhibitor.
Low hypoglycemic risk. And avoid sulfonylurea. Frail elderly will prefer DPP4.
Yes. Okay, then
high
hypoglycemia risk is there.
Yes, high hypoglycemia risk. Then preferred drug will be DPP4 inhibitor, SGLT2 inhibitor, metformin.
Okay.
Because minimal hypoglycemia risk.
Sulfonylurea insulin better to avoid or we will be cautious if hypoglycemic chance is there. Next one.
Need rapid HbA1c reduction.
Insulin, preferably short-acting insulin also, right? Or basal bolus together. Basal bolus combination.
Strongest glucose
lowering. Delay in symptomatic patients. Delay means?
I mean, in case of symptomatic patients, you
we shouldn't delay. We shouldn't delay. We have to start insulin because doctors are delayed. It is observation. It is found. The next.
Symptomatic patients start early. Symptomatic hyperglycemia, catabolism. So in that case, basal insulin preferred. Then because it controls severe hyperglycemia quickly. And plus avoid lifestyle.
No, not avoid. Lifestyle only approach will not be enough here.
Yes, sir.
That means if I tell, okay, change the lifestyle, I am not giving the insulin. Let's see after 3 months. We shouldn't do. Okay. Yes, now, Dr. Javed, I like to compare a little here again. Need rapid A1C reduction. And this patient also need rapid A1C reduction. Could be. Is that it? But difference will be that need rapid A1C reduction means very early we need to have reduction. But it is not too much early. Okay? Though there is a symptom, catabolism. So what I like to say, clinical understanding could be there that if any very rapid reduction needed, soluble insulin is enough. But it is not the actual treatment finally. We have to add basal bolus. But only symptom is there and we don't need to reduce immediate high blood sugar. Okay, within few days it is good. Then we can choose basal insulin. Basal insulin especially address the fasting level. Okay, not postprandial too much. Final one, let me say, Dr. Javed, thank you. The cost. My main focus is here also. Cost. Sulfonylurea is cheaper. So for this reason, Dr. Sharmin said that the insurance company prefers this sulfonylurea. But we have to prefer our patient if possible. Cheap and effective, and hypoglycemia weight gain is two important side effects. Okay. The next scenarios are there. Metformin intolerance. Dr. Sharmin, please continue. Please, other
Yes,
colleague,
sir.
don't mind. If you want to talk to us, if you feel better, you can raise the hand. Dr. Sharmin, continue. Metformin.
Clinical situation metformin intolerance. Then our preferred drug will be SGLT2 inhibitor or DPP4 inhibitor. Why preferred? Because good alternative options. Avoid or caution re-challenge if severe intolerance.
That means we will not re-challenge rather. Okay?
Yes,
If
sir.
we need to continue, we have to be cautious. That is the message. Try to understand the right column perfectly. Don't be confused. Next scenario, Dr. Sharmin.
Need oral weight neutral drug. DPP4 inhibitor. Why preferred weight neutral?
Okay, no
Here
need
nothing to avoid.
avoid other thing. Okay. Then
Marked insulin resistance. Pioglitazone. Improve insulin sensitivity. Avoid or caution heart failure, edema, fractures.
yes, if there is that chance, we will not use it. Anyone can say pioglitazone utilized in related in similar other clinical background. What is that disease other than diabetes?
Fatty liver disease.
Very
Fatty liver
right.
disease.
Very right. Fatty liver disease. Fatty liver disease. Continue, Dr. Sharmin. Next. History of
History of recurrent falls or dehydration. DPP4 inhibitor. Safer in frailty. Avoid or caution SGLT2 inhibitor. Use cautiously.
yes, we cannot use together DPP4 plus sitagliptin 2. Sitagliptin. Sorry, not sitagliptin. Sodium
We cannot
glucose.
use it. Yeah.
Use cautiously. We can, but we have to be cautious. In the
Cautious.
yes, in the frailty, because in the frailty there is chance of hypotension. Okay,
Yes, sir. Yes,
by
sir.
Sir,
by
I
this
have, sir,
SGLT2
one
inhibitor.
question regarding
Please,
this
please,
issue. Sir,
please,
please.
please.
Can we use DPP4 inhibitor and GLP-1 agonist simultaneously because those are increasing in creatine level? Is it recommended or not?
Not, no, it is not recommended, or actually initially in the guidelines, so far I remember in the previous guidelines, metformin can be combined with any other drug. 3, 4. There is no distinction. Nowadays, a restriction is already happened and you understood. So as this is oral drug, the DPP4 inhibitor, and there is an agonistic drug, there may be chance of synergistic effect. And by the synergistic effect, there may be the high in creatine related side effects. So I cannot answer your question as straightforward that don't use, but I like to say be cautious. Though it is not mentioned here. Though it is not mentioned here. It means that you can use with check and balance. Okay, doctor? With check and balance. Then very high
Very high HbA1c despite triple therapy. Preferred drug basal insulin plus minus continue metformin or SGLT2 inhibitor.
Better to
Why
continue all
preferred?
drug. Doctor, why
Yes.
you are reading like
Ye-
newspaper? You explain a little. Basal insulin plus minus means better to continue. Plus,
Yes, sir.
otherwise you have to increase very high dose of insulin.
Yes, sir.
Will your patient prefer it? You need to motivate your
No, sir.
patient. 1 week you have to
Yes.
take time to motivate the patient for insulin.
Yeah,
So
yes,
practical
sir.
thing is that continue metformin, sitagliptin. Sorry, I'm sorry. Always is sitagliptin, sodium glucose transporter 2 inhibitor, giflozin rather to say giflozin, metformin and giflozin and insulin. So why preferred advanced escalation?
Advanced escalation.
You increase the dose and others. So avoid therapeutic inertia. What does it mean? Especially for the insulin inertia, that you will not add insulin. Better not to do it. Okay. Let's see. Therapeutic inertia means let's see what will happen. Okay. Intizar shuaiya, like that. No need. Okay, doctor.
Yes, sir.
Thanking you. Just only few minutes remaining for us. And I don't know how much you are getting the benefit from today's discussion. Telling you some pre-diabetes issue about. Are you giving any medicine for pre-diabetes? Asking everyone. Please answer. Are you giving any
No, sir.
medicine for? No. Any doctor giving medicine? No?
No, sir. Sometimes giving
No, sir,
metformin.
only lifestyle and
Only
dietary
lifestyle.
modification.
So try to learn something today. Where can we
So
give?
sometimes giving, sir, metformin.
Sometime giving, but in general we are not giving. But sometime metformin when? How? Where? Dr. Sharmin? Randomly?
No,
Okay.
sir. Some
Obese patient.
patients who are obese and
Always
Obese
blood
patient,
sugar
yeah.
is also borderline. That kind of patient sometimes we are giving metformin, sir.
borderline for the first time
Yeah.
or
No,
repeated
sir.
time?
Not repeated time.
Repeated time. Let's see now and let's learn now. Be confident. In NICE guideline, these pre-diabetes termed as non-diabetic hyperglycemia, NDH. Okay, is a newer term. Don't be confused in the exam. NDH, non-diabetic hyperglycemia. So first job is lifestyle. Repeat HbA1c. If it is high, still persisting, not reduction is there. And worsening glucose. Glucose is becoming high up, but not crossing the diagnostic cutoff. At that time, you can use metformin. Okay. It is not for the weight reduction. Weight reduction drug will be actually semaglutide. But for the glucose, metformin, sometime it delay the development of type 2 diabetes. And sometime with the lifestyle, type 2 diabetes can be prevented. This is the very charming message for us and for the patient. Type 2 diabetes can be prevented. It was not true 10 years before. It is possible. So this is a very good idea now that metformin, but don't give metformin each and every patient as pre-diabetes. Okay. Now, in the South Asian people, now you will be surprised. I think today all are not South Asian. Few colleagues may be from Middle East countries also. Look at please, in South Asian population, including Bangladesh, they are high risk. It is very geographic, what I say, disadvantage. Dr. Litton, what do you say? Our birth is here means we are in the backward position. When to consider
Yes, sir.
metformin? When to consider metformin? If BMI is high, you just consider. Remember the word, doctor, meaning of consider. Consider doesn't mean advocate it, mandatory, not like that. You can consider. You can consider. So you need to discuss with the patient also. Okay. And if your insurance company does not allow, how can you advise? So consider, not that mandatory or prescribe. BMI is high, lifestyle change failed, progressive hyperglycemia, day by day increasing blood sugar, younger age with high risk. Two condition. One is the high risk, another is the younger age. High risk of what? Dr. Litton, high risk of cardiovascular, morbidity or mortality. Okay. And other features of diabetes, development of the high risk, dietary habit and other things. So younger patient, you have to give the metformin. Previous gestational diabetes. Dr. Litton and other colleagues, are we prescribing this? Patient have the gestational diabetes before. After the delivery, gynecologist tested and found blood sugar is normal, and then tell goodbye, doctor. See you again in the coming conception after having your new baby. These patients are missed. Clear? These
Yes, sir.
patients
Yes,
are
sir.
missed.
Follow up will be needed
Yes.
after at postpartum period.
Postpartum period, patient got blood sugar normal. Remember, I'm telling.
Yes, yearly follow up will be needed, sir. In that perspective.
Even the blood sugar normal also, we can give metformin. This is the message to the new message. Because there is a chance of development of the diabetes in future. So previous gestational diabetes, today you are seeing the patient, you can give metformin. Minimum in the low dose, doctor, only 500 milligram. Okay, it will be beneficial. Strong family history of diabetes. Though patient is in pre-diabetic state, the strong family history. So it is found in South Asian people. If you assess 100 people, how many percentage, Dr. Litton, will be having chance of having this or indication of using metformin? If you see 80 patient in your chamber in South Asian background, I think 70 to 80%. Those who are coming to the doctor, I'm not telling the population outside. They are having some disease otherwise. So a huge number percentage patient will be indicated for metformin. Though it is not mandatory, we can consider. So especially we will be in intention to prescribe metformin, especially if patient's BMI is more than 35. Okay. And South Asians may benefit at lower BMI threshold. If patient is South Asians, even you are working in the Middle East country, but patient is South Asian origin, I know that you are working with them also, you can use metformin. So these are very new thing. I believe that according to the guideline and the new research telling that we can modify our medicine. If no interaction, we can conclude now, doctor. Thank you very much. Do you have any question? Any addition? No more.
Sir, thank you so much, sir. My so many things got clear today.
Very good. Any other colleague to tell anything? I don't know any new colleague today. Please, for you, you can join with us again. It is my regular work to give you the AKT link and OSCE link if you want to be with us. Finally, come to these commercial, rather to say, right? Advertisement. Sorry to say. Those who are very new in the OSCE, is it OSCE? No, sorry, this is AKT. So it's our module, okay, AKT module, and this is the what is OSCE module. OSCE is being modified very soon. Already we have done modification. Okay. So talk to us personally if you need to join with us. Thank you very much for your patient hearing, doctor, and see you again in the next day.